Don't stop. Don't stop. Don't stop. Don't stop. Don't stop. Don't stop.
Management of otitis media. 1. Oral and topical painkillers are effective to treat the pain caused by otitis media. Oral agents include ibuprofen, paracetamol, acetaminophen, and opiates. Evidence for the combination over single agents is lacking. Topical agents shown to be effective include antipyrine and benzocaine ear drops. 2. Decongestants and antihistamines, either nasal or oral, are not recommended due to the lack of benefit and concerns regarding side effects. Half of cases of ear pain in children resolve without treatment in 3 days and 90% resolve in 7 or 8 days. 5. Antibiotics. It is important to weigh the benefits and harms before using antibiotics for acute otitis media. As over 82% of acute episodes settle without treatment, about 20 children must be treated to prevent 1 case of ear pain, 33 children to prevent 1 perforation, and 11 children to prevent 1 opposite side ear infection. For every 14 children treated with antibiotics, 1 child has an episode of either vomiting, diarrhea or a rash. If pain is present, pain medications may be used. For people requiring surgery to treat otitis media with a fusion, preventative antibiotics may not help reduce the risk of post-surgical complications. For bilateral acute otitis media in infants younger than 24 months of age, there is evidence that the benefits of antibiotics outweigh the harms. A 2015 Cochrane review concluded that watchful waiting is the preferred approach for children over 6 months with non-severe acute otitis media. A high-dose amoxicillin should be the initial treatment in the absence of a known allergy. The advantages of amoxicillin include low cost, acceptable taste, safety, effectiveness, and a narrow microbiologic spectrum. B. Children who have taken amoxicillin in the past 30 days, who have conjunctivitis, or who need coverage for beta-lactamase, positive organisms should be treated with high-dose amoxicillin/clavulanate, Augmentin. C. Cephalosporins, such as cefuroxime, Ceftin, may be used in children who are allergic to penicillin. Recent research indicates that the degree of cross-reactivity between penicillin and second and third generation cephalosporins is low, less than 10% to 15%, and avoidance is no longer recommended. D. Because of their broad-spectrum coverage, third-generation cephalosporins in particular may have an increased risk of selection of resistant bacteria in the community. E. High-dose azithromycin, Zithromax, 30 mg per kg, single dose, appears to be more effective than the commonly used 5-day course, and has a similar cure rate as high-dose amoxicillin/clavulanate. However, excessive use of azithromycin is associated with increased resistance, and routine use is not recommended. F. Trimethoprim/sulfamethoxazole is no longer effective for the treatment of AOM due to evidence of S. pneumoniae resistance. F. Intramuscular or intravenous ceftriaxone, Rosfin, should be reserved for episodes of treatment failure or when a serious comorbid bacterial infection is suspected. G-1 dose of ceftriaxone may be used in children who cannot tolerate oral antibiotics because it has been shown to have similar effectiveness as high-dose amoxicillin. A 3-day course of ceftriaxone is superior to a 1-day course in the treatment of non-responsive AOM caused by penicillin-resistant S. pneumoniae. Although some children will likely benefit from intramuscular ceftriaxone, overuse of this agent may significantly increase high-level penicillin resistance in the community. J. High-level penicillin-resistant pneumococci are also resistant to first- and third-generation cephalosporins. K. Antibiotic therapy for AOM is often associated with diarrhea. L. Probiotics and yogurts containing active cultures reduce the incidence of diarrhea and should be suggested for children receiving antibiotics for AOM. Persistent or recurrent AOM, 1. Children with persistent, significant AOM symptoms despite at least 48 to 72 hours of antibiotic therapy should be re-examined. 2. If a bulging, inflamed tympanic membrane is observed, therapy should be changed to a second-line agent. For children initially on amoxicillin, high-dose amoxicillin/clavulanate is recommended. 3. For children with an amoxicillin allergy who do not improve with an oral cephalosporin, intramuscular ceftriaxone, clindamycin, or tympanocentesis may be considered. 4. If symptoms recur more than 1 month after the initial diagnosis of AOM, a new and unrelated episode of AOM should be assumed. 5. For children with recurrent AOM, i.e., 3 or more episodes in 6 months, or 4 episodes within 12 months with at least 1 episode during the preceding 6 months, with middle ear effusion, tympanostomy tubes may be considered to reduce the need for systemic antibiotics in favor of observation, or topical antibiotics for tube otorrhea. However, tympanostomy tubes may increase the risk of long-term tympanic membrane abnormalities and reduced hearing compared with medical therapy. Tympanostomy tympanostomy tubes, also called grommets, are recommended with 3 or more episodes of acute otitis media in 6 months or 4 or more in a year, with at least 1 episode or more attacks in the preceding 6 months. There is tentative evidence that children with recurrent acute otitis media, AOM, who receive tubes have a modest improvement in the number of further AOM episodes, around 1 fewer episode at 6 months and less of an improvement at 12 months following the tubes being inserted. Evidence does not support an effect on long-term hearing or language development. A common complication of having a tympanostomy tube is otorrhea, which is a discharge from the ear. The risk of persistent tympanic membrane perforation after children have grommets inserted may be low. It is still uncertain whether or not grommets are more effective than a course of antibiotics. Oral antibiotics should not be used to treat uncomplicated acute tympanostomy tube otorrhea. They are not sufficient for the bacteria that cause this condition and have side effects including increased risk of opportunistic infection. Tubes are not indicated in children with a single episode of OM of less than 3 months duration, or in children with recurrent AOM who do not have middle ear effusion in either ear at the time of assessment for tube candidacy. Children with chronic OM who did not receive tubes should be re-evaluated every 3 to 6 months until the effusion is no longer present, hearing loss is detected, or structural abnormalities of the tympanic membrane or middle ear are suspected. Children with tympanostomy tubes who present with acute uncomplicated otorrhea should be treated with topical antibiotics and not oral antibiotics. Routine, prophylactic water precautions such as earplugs, headbands, or avoidance of swimming are not necessary for children with tympanostomy tubes. Special populations, 1 infants 8 weeks or younger, young infants are at increased risk of severe sequelae from suppurative AOM. Middle ear pathogens found in neonates younger than 2 weeks include group B streptococcus, gram-negative enteric bacteria, and chlamydia trachomatis. Febrile neonates younger than 2 weeks with apparent AOM should have a full sepsis workup, which is indicated for any febrile neonate. Empiric amoxicillin is acceptable for infants older than 2 weeks with upper respiratory tract infection and AOM who are otherwise healthy. To adults, there is little published information to guide the management of otitis media in adults. Adults with new onset unilateral, recurrent AOM, greater than 2 episodes per year, or persistent OM, greater than 6 weeks, should receive additional evaluation to rule out a serious underlying condition, such as mechanical obstruction, which in rare cases is caused by nasopharyngeal carcinoma. Isolated AOM or transient OM may be caused by eustachian tube dysfunction from a viral upper respiratory tract infection. However, adults with recurrent AOM or persistent OM should be referred to an otolaryngologist. Alternative medicine, complementary and alternative medicine is not recommended for otitis media with effusion because there is no evidence of benefit. Homeopathic treatments have not been proven to be effective for acute otitis media in a study with children. An osteopathic manipulation technique called the Galbraith technique was evaluated in 1 randomized controlled clinical trial. One reviewer concluded that it was promising, but a 2010 evidence report found the evidence inconclusive.